program by the federal government, enacted by Congress July of 1965 under the Social Security Act for those 65 and older. Now also, it's a program for people that are under 65 with certain disabilities. When somebody is under 65 and then been pronounced disabled by the federal government, after 24 months, the federal government automatically enrolls them in Part A and Part B, which is called Original Medicare. It's full Medicare. And so they can then go out and purchase a Medigap plan or a Medicare Advantage plan. And also the Medicare program is for people of any age with end-stage renal disease or permanent kidney failure requiring dialysis or kidney transplant. And that's very important that we know that, Medicare serves three groups of people. And so now to talk more about the changes that are coming up, we've heard a lot of changes about the number, what's going to happen, folks. It's very, very simple. All that is the federal government came up with a way to protect the beneficiary, meaning people that have the Medicare card, and take away their Social Security numbers, and then they're going to put in this Medicare beneficiary number, which is going to be scrambled. In other words, it's not going to contain their Social Security number anymore. It's going to be, they're going to start this April sending out new cards until next April. Everybody should have their own card. That's not going to affect anything at all. They're just getting a new card with a new number, and I would encourage them to reach out to, Medicare as well. So this is what the card is going to look like. Again, it's just going to be a Medicare number that's been scrambled. It's going to contain the same Part A and Part B effective date that they've had, so that's not going to do anything for you. Now, we're also going to update applications. So this month you should be okay, but make sure that we've got your email so that we're communicating, hey, this is the time for you to order new supplies. Obviously, if you are entering Medigap through the iGo application, you don't have to worry about nothing because all the forms are right there. And I recommend that's how you enter your Medigap forms as well, okay? And so let's talk about Medicare. One of the things that I'll share with you throughout the week there is that, particularly with my other webinar called Selling Clients New to Medicare, where I actually show you from all the 5 steps of the sale from A to Z, exactly how to conduct a Medicare review to go over their rights and options and what they're entitled to. One of the things we cover is we basically share with the client that Medicare doesn't cover everything. It just doesn't. And that's a myth that a client may have in their mind. Hey, how about eye exams and cosmetic surgery, routine foot care, acupuncture, all these things, long-term care, everything you see on your screen there is not covered by Medicare. Routine hearing exams is not covering, or hearing aids, eyeglasses or contact lenses. Now, that's within a point. If, for example, your client is involved in an accident and they damaged their mouth and their teeth and their eyes, it is going to cover to help them get better and stable. If they do have cataract surgery, Medicare does pay for one set of glasses, and but it's not going to be a fancy glasses or anything like that. It's very, very limited. So again, if you have something in your portfolio, such as a very robust, very good dental vision and hearing plan, you have long-term care, by all means, please make sure and take care of your client. But that's the first thing I tell them is that, listen, Medicare doesn't cover everything. And as an example, I like to plug this in here because in this example, according to a recent survey, a healthy 65-year-old couple, now this is a couple that's going to be retiring as of last year with a life expectancy of 85. And that's really low. The life expectancy is increasing. But that particular couple that's going to live to 85 will need an average of $260,000. And that's up from $245,000 in 2015 to cover medical expenses in retirement, folks. This is why that a Medigap plan is very, very important, that you gap the coverage, because that's a lot of money out of pocket. And I show you more about that in my Selling Clients New to Medicare, which is going to be, let me look at my schedule and let you know, that's tomorrow at 10 a.m. Okay, so let's go through the 4 parts of Medicare. The ABCs, right? The A is the hospital. The B is the medical insurance. The Part C is what they call the Medicare Advantage Plan, and this is one of the two options that the client has, right, with their Medicare card. They can either get a Medigap plan or a Medicare Advantage Plan. And then the Part D is the prescription drug plan, and that's what it is. So original Medicare only covers a portion of your hospital and medical expenses, but not all of them, and that's going to be very important that you share with your client. Now, obviously, a Medigap plan is one of the options, and it's going to help them cover much, if not many, on all of these expenses of Medicare allowable charges. We have plans. Obviously, the F plan is they pay a premium and everything is covered. So how wonderful is that? And later on, we'll discuss more about those options. So let's talk about now the Part A of Medicare. And if you notice there, if they go to the hospital from days 1 through 60, look there on your screen, and we have this chart right here that you can use during your reviews. They will have to pay, upon them being admitted to the hospital, $1,340 deductible. Now, that's going to be for the 60 days. But let's say, for example, the client is not, very, very lucky, and they're in there from days 61 to 90 consecutively. Well, from days 61 to 90, see right here, they have to pay $335 a day co-payment. That's going to total $10,050. And let's say in that same period, they're still in the hospital, they're in intensive care, God forbid something happened. They're in the hospitals from days 91 to 150. For those days right there, you see how this co-payment now begins to go up, and they have to pay $670 per day from days 91 to 150, totaling $40,200. Now, we're not due with the Part A. There's a couple of things here about Part A I'm going to show you. Obviously, if they're in the hospital that long, they're going to have to go to the skilled nursing confinement, and that's going to be to get some kind of therapy. The Medicare Part A, which is right here, all you got to do is read it right here. You know, if I say on a scale from 1 to 10, how comfortable are you with Medicare, and you say a 1, don't worry about it. We're going to give you all the training. As long as you can read, you can do this. But look at Part A right there. Part A is a hospital insurance and covers costs associated with confinement in a hospital or skilled nursing facility. So down here, obviously, going back to the scenario, they're going to have to go to the skilled nursing confinement to get some therapy. It does pay for 20 days, but starting from days 21 to 100, they have to pay a co-payment of $167.50 a day. And this is where a lot of clients think, well, I've got Medicare, original Medicare, so I don't need anything else, and that's not true, right? Because it only covers for 100 days. Let's say you're in the hospital for longer than that, for 5 years, for 10 years. Well, they need long-term care, and so this is very important that you point that out to them. Now, just to stay on Part A a little bit, again, that covers inpatient hospital care. That doesn't mean they can go get a private room. What that's going to cover, actually, it's going to cover a semi-private room. It's going to cover meals, general nursing, drugs even, prescription drugs as part of the inpatient treatment, and other types of supplies. And obviously, the inpatient care in skilled nursing or in a skilled nursing facility, this has to follow an inpatient hospital stay of at least 3 days. Now, keep that in mind. And it's all right there for you. In order to enter a Medicare approved, and it's got to be Medicare approved, SNF, stands for skilled nursing facility, within 30 days of their hospital discharge. And that's very important. A lot of people don't understand that. They get out of the hospital, maybe they've been there 5 days, and they stay out, 60 days, and they decided to use the skilled nursing facility. Well, they have to do that within 30 days of hospital discharge. It's going to pay, this SNF is going to pay for a semi-private room, meals, skilled nursing, and rehabilitative services, as well as other medically necessary services. It's going to cover supplies after a 3-day minimum. This is not, by the way, custodial care, okay, which is basically it's just non-skilled personal care help for activities to help, in daily living. In fact, in most cases, Medicare does not pay for custodial care, just so you know. So SNF is not, again, long-term care, and it only covers the first 20 days. The Part A also covers hospice care, and of course we know hospice care is the care for the terminally ill with a life expectancy of 6 months or less. And this includes, in the hospice care, pain relief, symptom management, medical, nursing, social services, drugs, and DME. And DME, all that is durable medical equipment, as well as aid and homemaker services. So it does cover hospice care. It also covers for home health care, part-time skilled nursing care, physical therapy, speech, language pathology services, occupational therapy, which is a form of therapy for those recuperating from physical or mental illness. It covers, the home health portion covers the medical, social services, part-time home health aid services, and DME. This benefit also, the home health care benefit, can also be used not only in Part A, but also is covered in the Part B as well. It also covers blood, believe it or not, and they must pay the first 3 pints in the hospital that they're in. And of course, one of the things I want to mention here about the Part A, and this is kind of problematic, you definitely want to point this out to your client. In that scenario that I just went through, you see these days 91 to 150, these days are called lifetime reserve days. And it says here that may never be used again. But if you think about that, you know, the title of those, the name of days 91 to 150, the lifetime reserve days, you would think that, you know, with a name like that, they would last a lifetime. But the opposite is true. Once the client uses, in that same period, days 91 to 150, they go away, essentially running, Medicare runs out, and they have to, you know, if that happens again, they're going to have to pay all the costs. So again, it's very, very important that you point that out to them, and this is why they want a Medicare policy, okay? After 151 days, if they're in there, Part A covers nothing. You see right here how that you can explain that to your client. Let's move over to Part B. Part B is medical insurance and covers the physician services such as outpatient care, the tests and supplies. This Part B has an annual deductible. It's pretty low. It's only $183. And then for these medical expenses, it's like an 80-20. So it pays, you know, 80% of the charges, and then the client is faced to pay the 20%. So again, another reason why you want a Medigap plan to gap Medicare. And so it's going to cover these medically necessary services, preventive services. It will cover preventive services like preventing flu or detecting it at an early stage, and a treatment such as that. There's a whole slew, there's like 30 different services that this Part B covers, and actually these 30 services are at no cost to the client. Now, if you're thinking to yourself, man, it's great information, I wish I could have a document or something to reference it, be of good cheer. I've written all this out for you. You can take it, you can study it, you can even point it out, point out some things as far as sharing it with your client, because I have it in a Medicare 101 document that I prepared, and everyone here is going to get that at the end of this webinar, so be of good cheer, don't worry, including those 30 services that are included in Medicare at no cost. And, just to let you know, some of those services, I'll just kind of read them off a little bit for you here so you can see it has, for example, breast cancer screening, mammograms, that's included, flu shots, lung cancer screening, prostate screening, diabetes screening, so colonoscopy. So these things are covered. That's also on in my document. And by the way, this is great for some of you folks out there that are selling and matching up our powerful HDF plan, or F Plus plan as we call it up there in New York State with Globe Life Insurance Company of New York, because, the premium is so low, it just has a $22.40 maximum out of pocket. You can then share with your client, listen, not only is the premium going to be low, but you've got 30 services that are included in that HDF plan or F Plus plan. And so that is wonderful information for you to share with your client. A couple of things I want to mention about this Part B, and these are the main things right here. And this, if you notice, these excess doctor charges. And basically what that means, if that provider does not accept assignment, meaning when Medicare says, hey, I want you to bill X amount for this particular service that you're giving, and if that doctor does not accept assignment, then they can effectually and legally charge up to 15% more. Now, obviously, there's some states that the excess doctor charges are prohibited, such as the state of Pennsylvania. It's prohibited. You can't charge excess doctor charges, and that's not an issue over there. Even Connecticut, and I know there's other programs out there, the ConMap and stuff of that nature. That has nothing to do really with the charging excess doctor charges, because that program there in Connecticut, you have to go and enroll, and it has some income requirements and stuff of that nature. But there's other states there on this document that I'm going to give you. I go over I think it's 8 states. Let's see, 1, 2, 3, 4, 5, 6, 7. Yep, 8 states, and whether they legally can charge in full or in part these excess doctor charges. And so that's going to be very, very important for you to understand and to share with your client. And so as you can see here, you know, you're coming up with a lot of money out-of-pocket exposure, and that's something that your client, you know, doesn't want to have. So the Part B, again, includes all of these services, ambulance services, diagnostic techs, all of the home health cares we covered. And so Part B covers this right here. Chemotherapy and all these things right here. Now, all of this is on my document. And again, we went over what assignment is, and that's very important, because if they do accept assignment, meaning they are a participating provider, you know, they're going to accept whatever Medicare says that this service should be charged at. For example, let's say that your client went in there and had an outpatient surgery. Which part of Medicare, Part A or Part B, is that going to be charged on? Is that going to be claimed on? Well, it's going to be Part B, because it's an outpatient surgery. And so obviously, if they're going to a participating provider that accepts assignment, and they want to charge, for example, $50,000 for the surgery, and Medicare comes back and says, no, you know what, this service can only be charged at $30,000, then that is the price that service is going to be charged at. Okay, understand that. But if the provider is not participating, then they can charge patients up to 15%, obviously, with the exception of those 8 states that charge in part or in full excess doctor charges. So that's all about excess doctor charges, and that's what it is. And that's why, folks, that I train that you will only sell 3 plans. I know there's other plans there, and you can, you know, as you're sharpening the saw, and you can then branch out and sell the N plan and the L plan. But other than that, no other plan should you sell other than the most comprehensive plan, which is the F plan. They pay a premium, everything is paid. Or the G plan, which, you know, when you sell that plan, the premium's usually lower, and they'll have to pay that $183 Part B annual deductible. Once they pay that, the G plan essentially converts into an F plan. And then, of course, you have the powerful HDF or F plus plan, where they're paying a low premium, and then they have a $2240 maximum out of pocket. I will tell you this, on that HDF and F plus plan, I mean, in order for them to meet that $2240 maximum out of pocket, I call it maximum out of pocket instead of a deductible, is they would have to be in the hospital for like 64 consecutive days in a row. I mean, you know, it's very unlikely it could happen, but if that happens, you know they're in intensive care, and their bill is going to be well over $100,000. Their portion is $2240, and then for the rest of the year, it's paid at 100%. So, you know, it's just a fabulous plan again. Now, again, let's take a look at these MA plans, and that's what they are. They are plans. It's not an insurance policy like Medicare, but it's because it's a yearly contract between the federal government and that private insurance company. Okay, some of them may have monthly premiums, some of them may have you know, no premiums, but the maximum out-of-pocket costs for these MA or MAPD plans are usually more than the Medigap plan. In other words, they're going to pay more out-of-pocket when they start really using this, and God forbid if something catastrophic happens. Plus, remember, and I think I have slide in here that says, that with these MA plans, they will have to go to in-network doctors only. They cannot just choose any doctor, any hospital, anywhere in the country. And so, of course, when I say MA or MAPD plans, some of these Medicare Advantage plans, the clients purchase a separate Part D plan, or some of them may include the Part D plan, therefore they are considered an MAPD plan, a Medicare Advantage prescription drug plan. Now, MA plans must, by law, cover all of the services that original Medicare Part A and Part B covers, at the minimum. They may also have additional benefits, and usually they do. They have a little dental plan in there, which is really not comprehensive. It's good for cleaning, I guess. They also might have a gym membership. And each MA plan can charge different out-of-pocket costs, have different rules for how you get your services, such as needing referrals for specialists or going to a certain network of doctors and hospitals that belong to the network. Of course, the rules change. And again, this is not a guaranteed issued plan. You cannot guarantee the client that they're going to have this plan, the same plan, year after year after year, because they do change their benefits and their premiums as well. You do have a right and option each year during what they call the AEP, the annual enrollment period, which starts from October 15th through December 7th, to keep that plan or to choose a different plan or switch back to original Medicare, and then they can purchase the Medigap plan if they qualify. So again, when your client gets this MA plan or MAPD plan, they are locked in until the end of the year. Now, there are different kinds of MA plans, such as, PPO, HMO, PFFS, and then those SNPs, what they call those SNPs, are special needs plans for people usually that are dual eligible. We call them, like, for example, they have Medicare and Medicaid, and make sure you make a differentiation between the two, because Medicaid is a federal and state program for people with limited financial resources. So if somebody has a Medicaid and a Medicare, in other words, they're dual eligible, that's what that means. You cannot and should not sell them a Medigap plan. Just put them in an MA plan. That's better suited for them. Okay? Now, again, MA plans are not guaranteed renewable. Premiums change, benefits change, networks. The maximum amount of pockets typically are higher. The average is about $6,700. I know here in Texas, if you purchase an MAPD plan, and you purchase the plan too, but with United Healthcare, you will have to pay a premium of $78, which is going to bring your maximum out-of-pocket down from $6,700 or something like that, all the way down to $3,500. But again, just to put things in perspective, again, here in Texas, for example, this is where our corporate office is that you can put an HDF plan in place, which is similar to that MAPD plan, only it's going to give them a lot of freedom, for an average premium starting at $27 a month, and lower their maximum out-of-pocket cost to $22.40. You're going to give them all of the freedoms, the bells and whistles for a Medigap plan when you place that HDF plan in place. And again, this can really help the senior, give them that security and stability that they need. Remember that when you sell a Medigap plan, you will also have to put in place a Part D prescription drug plan. You don't want them to go without, because if not, the government may assess them a penalty, and that is not good. Now, obviously, we only have a limited time to being together. What I'm going to do in the email, if you have not purchased actually, it's not a purchase. You can just request it at Medicare.gov. Go there and order the Medicare and You book that is given to every single senior every single year. It's a brand new, Medicare and You book. It goes over a lot of information there. Go ahead and highlight the information. Continue to sharpen the saw, and then carry that to your visits. Carry that to your Medicare reviews, so you can show them in writing what the federal government says. The other publication that I recommend you have, that I'll also give you in this email, is the Choosing a Medigap guide booklet. And that's something you have to give to everyone that is purchasing a Medigap plan. But obviously with us, if you're doing it through the iGo, it's all electronic and they're good. But nevertheless, it's called the Medicare Buyer's Guide. Order one for you. It's free. It doesn't cost you anything. Obviously, you want to have a couple in there with some paper applications in case you're not getting internet access and etc. But going back to the Part D, there's no qualifying for that. So if your client is not taking a lot of medications, make sure and explain to them, listen, go ahead and get one right now. You can get one for a very, very low price. Every single year you can change it. There's no qualifying for it. But let's go ahead and get you on right now so that you're not paying this penalty. And remember, if you can do it yourself, if you're certified through an MA carrier to offer that to the client. If you don't have that certification, no problem. All you have to do is direct them to call 1-800-MEDICARE, 1-800-MEDICARE, and they can do it over the phone, or if they're pretty savvy, they can go to Medicare.gov. It takes about 10 minutes for them to select that. And or they can also go to their pharmacist. A lot of times their pharmacist can direct them on how to sign up for that as well. And so again, prescription drug plan, very, very simple to get, and you want to definitely do that. So let's talk about signing up for Medicare, right? When somebody, how can somebody sign up for Medicare? Well, if they're working on the railroad, right, on the Railroad Retirement Board, this is automatic enrollment for them. So if you have any clients that worked in the railroad, they're retiring, everything is automatic for them. And remember, when somebody is going to be turning 65, they have the IEP, or the initial enrollment period, which means that they can sign up 3 months before the month that they turn 65 and then 3 months after. Don't confuse that with us granting you the ability, if you knew this or not, that you can sell our Medigap plan 6 months before these clients actually enroll in Medicare, and that's pretty powerful, except in 2 states, in New York and in Wisconsin. So those are the only 2 states. Has to do with your state. Now, and that's going to give you a big competitive advantage. Now, if the senior doesn't sign up when they're first eligible, then the senior it may, again, get a late enrollment penalty for not signing up for the Part B. Obviously, if they're still working, right, there's not going to be any penalty because they have credible coverage. They have the group coverage. Once they lose the group coverage, then that's when they're going to have to sign up for the Part B. Now, folks, that concludes our training today. Make sure that you're out there helping your seniors. Obviously, here we're going to go to the fabulous Las Vegas. It's February, so you have a lot of time to qualify for that. And the good news is all you have to do is help 100 clients this year with our Medigap plans. It doesn't matter which one you help them with, and that's going to be so wonderful for you. All right, folks? I'm going to go ahead and open it up for any kind of questions that you have. If you have any questions, go ahead and type them in, and I will work on that email, have my admin send an email